Hello. Rai. Brian.
Hello, Doktora. Doktora si...
Brian.
Yes po, Doktora.
Nakapasok ako sa aking iPad, pero mahihirapan ako i-shift papuntang... but let me see. Ano ang password, Kalbe?
Po, nandyan. Opo.
Jesus, kanina pa ito, paulit-ulit. Pero nakapasok na ako, but I use my kasi baka hindi, I cannot, magkakaroon ng time.
Yeah, opo.
Mahihirapan ako sa pag-shift.
Ng ng slides, Doktora, I understand.
Oo, ng shift. Ng slide. Kasi pag-iPad mas mahirap eh.
Doktora, naka-live na po tayo dun sa ibang Opo.
Okay, no, don't talk na.
Thank you, Doktora.
Intakan Justin, adan Justin paano? Intakan kin, intakan kile.
Kabila makano to. Yeah, jak him. Yama. Kanin, jak him na. Sino? Isa na.
Taray away ang
Okay, good morning, everyone. Good morning to all our participants. We will be starting in a few minutes. So just please relax, and in 2 minutes times we'll be starting.
Good morning, everyone. I'd like to remind each and every one of us to please mute our cell phones or our devices. Thank you.
Pa-mute po ng audio.
Okay, good morning. Good morning, everyone. To all our viewers, good morning. I'm CD Brian Sevilla, and I represent Kalbe International, Pharmacology and Adult Nutrition Division. Kalbe International Philippines aim to provide quality medical products to further uplift the health and well-being of our fellow Filipinos. In line with this commitment, we provide affordable, premium nutritional and pharmaceutical products, all of which have passed the highest quality and approved standards. Two of these products are ceticoline Calbrain and for neuro repair and neuroprotection in cognitive impairment and stroke. Another is diabetasol diabetes nutrition solution. Okay. This medical webinar is momentous for us, for this serves as a means for Kalbe International to further realize our goal, which is to provide medical education to our hospital care practitioners. Today, we are further enlightened on the collaborative strategies for metabolic syndromes from three distinguished speakers, Dr. Rosa Allen, GC, Dr. Jennifer Justice Manzano, Honorable Bridget Buena. Okay. So as house rules, it's not. Do you see the slides? Hello.
Yes, sir. We see your slides.
Okay.
Yes.
Thank you. We request everyone to mute all our microphones while lectures are ongoing. No taking of pictures and posting of contents, lectures on social media. We also request everyone to type in their questions in the type box. Okay. For our post-webinar attendees will be personally followed up by each territory managers for e-certificates, and unanswered questions will be entertained as well. You may also send your feedbacks to us or our territory managers. I'm also honored not only to open this event, but to introduce our moderator for today. Our moderator for this webinar is an accomplished nursing and paramedical course, finished Doctor of Medicine at Ateneo de Manila University School of Medicine and Public Health, underwent adult neurology training program at the Medical City, and he was a chief resident in 2017. He also had his preceptorship training at Johns Hopkins Hospital as a neurocritical care and neuropathology. Also, a visiting consultant in all major hospitals in Baguio. Our moderator for this webinar, Dr. Manolo Christopher C. Flores.
Thank you very much, Sir Brian. Ladies and gentlemen, I am Dr. Christopher Flores, and it is my privilege to be your moderator for this webinar entitled Collaborative Strategies for Metabolic Syndrome Management. In a few moments, we will be starting our lectures. Sit back and learn from our experts. To kick off our lecture series, I am glad to introduce to you our first speaker. She's a diplomate and fellow of the Philippine College of Physicians, a diplomate and fellow of the Philippine Society of Endocrine, Diabetes, and Metabolism. She is a leader. She is the past president of the Philippine Lipid and Atherosclerotic Society, the Philippine Society of Endocrine, Diabetes, and Metabolism, and the Philippine Diabetes Association. She received multiple prestigious awards, which include the PCP Exemplar Award in Clinical Practice in 2016 and the Distinguished Internist Award. She is currently the Director of the Research Development and Innovation Division of Hospital ng Makati, the head of the Section of Endocrinology and Metabolism in Cardinal Santos and Medical Center and Hospital ng Makati. She is the current chair of the Nutrition Support Therapy at Hospital ng Makati, and she is currently a clinical consultant at the Cardinal Santos Medical Center, the Medical City, and the Hospital ng Makati. To give us a lecture on metabolic syndrome and stroke, complexities, trends, and treatment, let us all welcome Dr. Rosa Allen C.
Wait, let me share my slide.
Paadit, please,
Can I-
in favor to please project the slides.
Wait, I can have my slides, but I can't seem to
Yeah, Dr.
share it.
Yeah.
Screenshot ako ng screenshot.
It's already. Can you see it now?
Yes,
Yes,
ma'am.
Dr.
We can see
You can see my
Yes,
slides
Dr.
now.
Yes,
Yes.
Dr.
This is my slide. Thank you very much, Dr. Flores, for your kind introduction. Thank you, Kalbe Philippines, for inviting me as well to Honorable Virgit Rena for making me part of this symposium. May I request everyone to please mute their microphone. Let's just have the speaker have their microphone on so as to avoid the unnecessary sounds. So for this morning, I am honored to present to you metabolic syndrome and stroke, its complexities, trends, and ends. These are my... Wait. I cannot move my slides forward. Wait, these are my disclosures. And for the next 20 minutes or so, I'll try to provide you and review with you the definition, classification of metabolic syndrome, the epidemiology, prevalence, incidence, and trends of metabolic syndrome and its risk factors. Also provide with you and review with you the pathophysiology and complexities, as well as the treatment of metabolic syndrome. By definition, metabolic syndrome refers to the cluster of conditions that occur together, increasing one's risk of heart disease, stroke, type 2 diabetes mellitus, excess body fat around waist, and abnormal cholesterol or triglyceride level. As you see in this in the picture on the right, it is the patients who have apple-shaped body apple shape are the ones that are exposed or at risk for metabolic syndrome. The concept of metabolic syndrome or syndrome X, that was what it was called in 1988, was actually presented to the medical world by Professor Riven in 1988. Through the years, it has actually changed its nomenclature. It became the insulin resistance syndrome, and now it is known as the metabolic syndrome. So in 1988, Professor Riven noted that there is increased risk for coronary artery disease or atherosclerosis for those patients with clustering of hypertriglyceridemia, low HDL, cholesterol, hypertension, and the background that most of these patients have hyperinsulinemia. Since hyperinsulinemia is believed to be the cause of syndrome X, WHO and the group of the European Group of Insulin Resistance has suggested to change the name from syndrome X to insulin resistance. And here they define classification as the presence of one, either insulin resistance, IGT, or type 2 diabetes, plus any of the two, like hypertension, increased triglyceride, low HDL, central obesity of ratio of greater than 0.9 for men and 0.85 for women, and a BMI of greater than 30, and a microalbuminuria of greater than 5 micrograms per kg, or an ACR, elevated ACR. So the metabolic syndrome in the year 2001 was actually renamed. This is as a expanded definition of insulin resistance syndrome. Here, aside from the insulin resistance, IGT, hypertension, low HDL cholesterol, high triglyceride, coronary heart disease, and premature death, they included upper body fat or visceral fat, apolipoprotein abnormalities, hypostasis, and hypofibrinolysis. Different classification as proposed by different societies has been given, like the NCEP 2001, AACE 2002, IDF 2005, and the NCEP AHA NHLBI 2005. However, because of the many definitions provided, the expert decided to harmonize the definition of the AHA, NHLBI, and IDF. And here, and this slide just tells you the different classification. Since the NCEP 2001 is from America, they actually use the waist circumference of 102 centimeter, greater than 88 for women, lipid or triglyceride of greater than 150, HDL of less than 40 or less than 50 for women, blood pressure of greater than 130, fasting glucose of greater 110. In 2005, the IDF group, however, suggested a different classification, emphasizing the presence of waist circumference. So in this classification, they require that all patients to be diagnosed with metabolic syndrome, they need to have an increased waist circumference, which is population specific, with the different, plus any of the three components like triglyceride, elevated triglyceride, low HDL, elevated BP, as well as elevated fasting glucose or diabetic on treatment. In 2005, also, the ACEP AHLBI provided a different definition. This time using using the IDF ethnic specific waist circumference, but they suggest that to be classified as metabolic syndrome, they have to have any of the 5 features. Unlike the IDF, that they require that all metabolic syndrome patients should have an increased waist circumference. But remember that there are some patients with a metabolic syndrome or insulin resistance who are actually lean. So because of that, the experts came together and formed the 2009 harmonized definition of metabolic syndrome. And this includes an elevated waist circumference, which is population or country-specific definition, elevated triglyceride of greater than 150, reduced HDL, as presented here, and elevated BP, whether they're hypertensive already with antihypertensive drug, and elevated fasting glucose, or those already diagnosed to have diabetes on medication. In our NNS and Hayes data, they actually use the Asian cutoff of greater than 90 for men and greater than 80 for female. So having said that, it is important to remember that visceral fat is very important in the development of the different metabolic abnormalities as presented in this slide. And this is brought about by the different, our lifestyle, sedentary lifestyle.
Yeah.
Mm.
Hello, Dr. Rasai.
Yeah, naka-mute.
Cannot hear your voice.
Okay, now?
Yes, ma'am.
I
You're
don't know
speaking
what
loud here.
happened. Somebody. Okay. So as I've said, visceral obesity is an important factor in the development of the different abnormalities, metabolic abnormalities, brought about by sedentary lifestyle, aging, diet, and genetics. And this is believed to be brought about by an important problem called insulin resistance, which serves to be the central problem in the development of metabolic syndrome. Let us now take a look into the different trends of the different components of metabolic syndrome. If you look at this slide that I'm presenting, the global trends of obesity is increasing. And if you look at the Asia, although it actually is at the lowest trend, or the lowest of the graph, our region still has a progressive increase in the number of people getting obese. And look at the trends in diabetes. There is a significant rise in the number or in the prevalence of diabetes globally. This is from the IDF Diabetes Atlas 2017. So it is now in 2017, it has been reported that globally there's about 425 million people suffering from diabetes, and that in 2045, it is expected to rise to as high as 640 million diabetic patients. So what is the prevalence of malnutrition in adults greater than 20 years of age from 1993 to 2013 showed that there is an exponential increase in the prevalence of obesity in our country, while there is a slight reduction in the chronic energy deficiency in the country. And look at the waist circumference. The trend is significantly increasing both in male and females, although it's exaggerated in female. In both gender, male and female, there is a rise in the waist circumference as well as in the waist to hip ratio. How about hypertension? In the hypertension, the prevalence of hypertension is noted to decrease in 2013, while the prevalence of diabetes has increased significantly from 4.8 in 2008 to 5.4 in 2013. I have the privilege to attend the webinar of the End of Vision plenary session of PSEDM, where Dr. Agdepa presented the 2018 FNRI DOST and NNS survey on obesity and fasting sugar. You will look that from 2013, there is a 31.1, and now in the 2018, there is a significant rise in the prevalence, almost 5% rise in the prevalence of overweight and obesity in the country, while there is a significant drop in the prevalence of chronic energy deficiency. And if you look at the fasting sugar from 5.6 reported in 2013, it's now 8.2%. So there is really a significant increase in the prevalence of these component risk factors of metabolic syndrome in the country. I have earlier mentioned that of all the prevalences, it's only hypertension that actually saw a slight drop in the prevalence of hypertension. The green bar here refers to the 2018 result, and the 2015 result here in the red bar. And you will note that across all ages, the prevalence of hypertension in our country decreased. So we hope that with this, we can improve the risk factors associated with hypertension. So how about the prevalence of stroke in the Philippines? In the 2013 data, the overall stroke affects 1 in every 100 Filipino adults, or 1.4%, and that which was similar to the 2003-2004 NNS and NHES report. And similar to angina, adults aged 70 years and over had the highest prevalence based on the previous history of stroke of 6.3%. male was affected more at 1.6% than female of 1.2%. So what is the prevalence of metabolic syndrome in the country? Is it just a medical concept or does it really exist? So sharing with you the data of the group of Dr. Morales published using the 6 NNS data, 2003 and 2004, showing that the different definition, the NCEP ATP3 AHA definition has the highest prevalence of 18.6%. And if you look at the different individual component of risk factors in the general population, we are unique in the sense that the country or the Filipinos has the highest prevalence of low HDL, which is 70.2%, 33.3% of high BP, 26.1% of increased waist circumference, 20.6% of increased triglyceride, and 7.1% of elevated blood sugar. Analysis of this data showed that using the 3 different classifications of metabolic syndrome, MS predisposes Filipino population to DM and stroke. They increase the risk for diabetes by 2 to more than 27-fold, while it predisposes stroke by 138 to 199%. When using the IDF definition, MS was also predisposed to myocardial infarction more than 21-fold. There was no association, however, of even a reverse association between metabolic syndrome and angina, as well as metabolic syndrome and peripheral artery disease. Our group, actually, Dr. Florentino and Ms. Duante in 2004 analyzed the 6 NNS and NHES data 2003, looking into the correlation of body fatness and increasing risk of related comorbidities among adults Filipinos. And in this data, we have noted that the tentative cutoff BMI for Filipinos for overweight is 23 and 27 for obesity, while the waist circumference is 90 centimeters for males and 85 centimeters for women, while the waist to hip ratio of 1 for male and 0.95 for females. These tentative cutoffs were closer to the recommended cutoff for Asia Pacific Islanders and Asians, or the IOTF, lower than the WHO cutoff mentioned earlier. In 2008, we actually also analyzed the data of the 7 NNS data, and this data showed that odds ratio of developing 2 or more risk factors among adult Filipinos were noted to be even at a BMI of 18, both for male and females, meaning at the lower BMI, we can start getting comorbidities already. And that the tentative cutoff from the 2000 data were 22.3 as compared to 23 from the 2004 data, and for overweight, and 27 for obese, which was similar to the 2003 data. The waist circumference is 78 for both male and females, while the waist to hip ratio was 0.92 for males and 0.88 for females. So why is it so? Why are we getting different, why are we getting a lower BMI and developing comorbidities? And I think this is because of the tendency to adiposity in Asians. This picture is familiar to everyone. This picture shows that for two individuals with the same BMI of 22.3, if we measure their body fat, the man on the left has a 9.13% body fat as compared to the person who looks leaner, who has a 21.2% body fat. And this is what we call the thin fat Indian body, wherein one exhibits a thinner, shorter, lighter, more body fat, but paucity of non-fat tissue. And if you look at this is data from Professor Araneta and her group from San Diego, published in 2004. And much later data also confirmed this data, that a Filipina who's a BMI, much lower BMI of 20 as compared to the African American BMI of 25, has much visceral fat as compared to the African American whose visceral fat is much lower. So this explains why Asians or us or Filipinos develop more comorbidities at a much lower BMI. So what is the prevalence of metabolic syndrome now using the 2008 NHES data? Here it says that the male prevalence metabolic syndrome is 25.8, females of 28.9%, and an overall of 27.4. And if we compare it to the 2003 data, it increased significantly by almost 10% because in 2003, the prevalence was only 18.6% using the combined data of AHA. Now, if you look at the different components, still the highest is low HDL. The highest prevalence is in the low HDL, and comparing it to the previous data from 70.2%, it went up to as high as 80.3%. And for waist circumference from 26.1, it was close to 30%. Fasting sugar, 7.1%, is now as high as 12.2%. So why are we so concerned about metabolic syndrome? As clinicians, we're concerned because it has been shown to increase CVD and all-cause mortality. The green line here refers to those individuals with metabolic syndrome. And it actually shows that there is a steep increase in the all-cause mortality if the patient has or if the person has metabolic syndrome. And in the Beaver Dam study by Professor Klein and his group published earlier in 2003, he actually showed vividly that there is an association between the numbers of metabolic syndrome components and the incident CVD. The risk increases as the number of components increases. So here, if a person has only one component, there is a 2.5% risk of developing CVD and so forth. But if the patient has or the person has more than 4 components, it goes as high as 14.9%. And a patient who has one component has a risk of getting 1.1% of developing diabetes in 5 years. And that if the patient has four components of the metabolic syndrome, they can get a 17.9% incidence of developing diabetes in 5 years. So as early as that year in 2003, they cannot really explain why all of this is happening. And that what they know is that metabolic syndrome is known as a CVD independent risk factors. But now we know a lot about diabetes and metabolic syndrome and stroke, so we can explain why patients with metabolic syndrome are at higher risk to develop coronary artery disease and as well as cardiovascular disease. However, in this study, they have pointed out that the components of the metabolic syndrome are common and are associated with incident cardiovascular disease and diabetes after 5 years. Hence, having said that, intervention to alter BMI, lipid levels, and blood pressure may decrease incident diabetes and cardiovascular disease, suggesting therefore that though we look at the different components of metabolic syndrome, we need to prevent and to focus on the different components of this metabolic syndrome. And why is it that as the number of components increases, the risk for CVD increases? This is so because they have noted that there is an elevation in the number or in the magnitude of CRP once the number of components of metabolic syndrome also increases. And this can explain the increased inflammatory reaction of the person. This research was early on presented in one of the annual convention of neurology, American Convention of Neurology. And this is a research in Manhattan, New York City, involving 3,298 stroke patients that were followed out for 4 years. And actually they showed 42 prevalence of MS amongst the stroke patient and 128 had first stroke during this period. So people with metabolic syndrome were known to have 1.5 times more likely to develop a stroke than people who did not have the syndrome, and that people with metabolic syndrome were 2.1 times more likely to have a stroke than those without the condition. Study participants with metabolic syndrome were also more likely to develop heart attacks and die of cardiovascular related causes than those without the syndrome. Metabolic syndrome was more prevalent among Hispanics than other than whites and the black, and that it was stressed that the study found an increased risk of stroke for all people with the metabolic syndrome, regardless of race, age, or other factors such as physical inactivity and current smoking. And when we use and in this study, 2005, when they use the WHO definition, the metabolic syndrome has a stronger predictive value for the risk of CVD events than any of the component. So if you look at this slide, you will note that with the metabolic syndrome, it increases the risk for coronary heart disease by 3 folds, by MI by 2.63 folds, and stroke by close to 2.27 fold. So what is the prevalence of stroke in metabolic syndrome? The Hisamaya study in Japan has reported that the existence of metabolic syndrome, increased the incidence of stroke by 1.9 and 1.5 in females and in males and in females. And between hemorrhagic stroke and ischemic stroke, it is ischemic stroke that is associated with high risk of CVD events in many studies. Liu suggested that there is a dose-response correlation between meds components and the risk of CVD events, with a hazard ratio of 5.1% for ischemic stroke and 3.3 for hemorrhagic stroke. So in another study, the prevalence of hypertension was significantly high in stroke patients compared to the control, and that fasting sugar measurement of more than 110 was also noted among stroke patients compared to the control group. This is seen in the Iran study group. Similar to the Korean study, Huang et al., which is a Chinese study, showed that demonstrated that metabolic syndrome and FBS were the highest predicted factors for CVD. In this study, the Thai epidemiologic stroke study is actually a very interesting study because they have shown that among the components of metabolic acidosis, high blood pressure and hypertriglyceridemia confer the greatest risk for stroke. Although they have found an increase in waist circumference, the presence of high blood pressure and hypertriglyceridemia is present in most of these patients with stroke and suffering with metabolic syndrome. The risk associated with metabolic syndrome is not greater than the sum of the risks associated with the individual components of metabolic syndrome, suggesting that although the presence of metabolic syndrome increases your risk, it is very important that each of these component risks actually contributes to the risk for CVD incident. And that they suggested our focus should be on the identification and appropriate control of these individual components, particularly high blood pressure and hypertriglyceridemia, rather than metabolic syndrome itself. This Japan study, however, showed that the prevalence of metabolic syndrome as well as hyperglycemia and dyslipidemia in the infarction group was significantly higher than that in the non-stroke group, and that the hemorrhage group showed no significant difference in the prevalence of metabolic syndrome, and that only hypertension in this group was significantly high. So in Egypt, which is a much later study, metabolic syndrome was of higher frequency in atherothrombotic stroke of as high as 76%. It was more in females and older age. Metabolic syndrome with diabetes patients had the worst clinical presentation and the worst in-hospital outcome. And that interesting that high density lipoprotein cholesterol was the predictor of worst clinical presentation. They have suggested that probably this is because of the high molecule or high HDL that becomes more non-protective as the size of this HDL increases. So why are we talking about visceral fat and all of this as a cause of metabolic syndrome? This is because visceral fat is a metabolically active infiltrated with different inflammatory cells as indicated in this slide. And that if you compare it to the normal fat has anti-inflammatory adipokines, and this is called as the adiponectin, compared to the dysfunctional fat where they have mostly pro-inflammatory adipokines. And here, the different adipocytokines are presented here, leading to the different metabolic abnormalities and ultimately atherosclerosis. So everyone has forgotten adiponectin. Not much are actually said about it anymore, but it is just important to mention that adiponectin is expressed only in the adipocyte and it is only known adipocyte secreting factor that increases tissue sensitivity to insulin, and that it is markedly decreased in type 2 diabetes and obesity, and that the magnitude of reduction is strongly correlated with the severity of insulin resistance in peripheral tissue, muscle, and liver. And that this is a very potent anti-inflammatory agent that inhibits a number of steps involved in the development of atherosclerosis. And this is so because as the visceral fat accumulation increases, the plasma adiponectin, which is supposed to be our protection, is actually decreased. And here is just a slide depicting that with the low adiponectin level produced by genetic variation or visceral fat accumulation, there are several metabolic abnormalities, including the metabolic associated fatty liver disease, which we used to call as NAFLD. Plasma adiponectin and coronary artery disease is directly associated. The higher the adiponectin, the lower the risk for the problem or higher cumulative survival rate. So what is the cause of insulin? What is, again, focusing on the insulin resistance as the cause of metabolic syndrome leading to atherosclerosis? I just want to emphasize that it is the large insulin resistant adipocyte with increased adrenergic receptors and low adiponectin that leads to increased insulin resistance, increase in the free fatty acid, which will ultimately lead to the different abnormality, including the endothelial dysfunction and inflammation, like an increase in CRP and MMP3, and now microalbuminuria. So metabolic syndrome is really a metabolic time bomb. So with the linear increase of elevated risk of diabetes and cardiovascular disease from the metabolic syndrome, there is an urgent need from us clinicians to intensify our strategies to diffuse this metabolic time bomb. So these are just the list of the management of metabolic syndrome. As I have mentioned earlier, and as I have emphasized, it is the insulin resistance that is the core of the problem. So it is better, or it is needed, that you treat insulin resistance. So how do you treat insulin resistance? You treat the visceral fat, excess visceral fat, through weight reduction. Weight reduction can either be non-pharmacologic or pharmacologic and surgical. So our third speaker, Honorable Virgin Buena, will talk about the lifestyle change, the necessary things that you need to do to help your patient lose weight. Pharmacological intervention, since we're talking about insulin resistance, we need to use something that will target insulin resistance. Insulin sensitizers like your metformin and your TCDs. Bariatric surgery does not actually reduce the visceral fat, but with metabolic surgery, it might actually help the individual lose weight because of the reduction either in ghrelin or leads to restrictive surgery, as well as the malabsorptive surgery, all of which can contribute to weight reduction. Treating dyslipidemia is very important because the patients, as mentioned earlier, the most common component factors seen amongst these metabolic syndrome patients are hyperdyslipidemia. So in this case, statin is still the main treatment for our patients suffering from dyslipidemia. For diabetes, there's now several drugs to treat diabetes, and our goal is to keep their A1C to goal. And then also to make sure that there is less glycemic fluctuation or variability, as this actually is associated with cardiovascular disease. Now, what is the choice for your medicine? What is the choice of the diabetes drugs among your patient? You need to take into consideration the age of the patient, the lifespan of your patient, the onset of the diabetes, as well as the presence of comorbidities. So if the patient has either atherosclerosis already or renal problem, you may actually look into or choose GLP-1 receptor agonist or the SGLT2. But if the cause is the problem, then you can think of metformin and other drugs like TCGs, which are less expensive. And the treatment of hypertension, still for the obese patient, will be our ARBs and ARB, as well as angiotensin 1. So we have to really make sure that they are provided and keep their blood glucose, hypertension or BP control down to acceptable range of less than 130/90. So in summary, the prevalence of different components of metabolic syndrome is significantly increasing in the Philippines, and hence the prevalence of metabolic syndrome in the country has likewise noted to increase from 18.6% in 2003 to 27.4% in 2008. The increase in dysfunctional visceral fat cells leads to hyperinsulinemia, the core in the development of metabolic syndrome, and that the presence of metabolic syndrome increases the incidence of CVD. The risk of CVD incident increases as the number of component risk increases, and that the prevalence of metabolic syndrome increases the prevalence of stroke. Hyperglycemia, hypertension, and hypertriglyceridemia have been reported to be the most commonly associated risks for stroke, and therefore the management should be directed towards the prevention and treatment of the individual components of metabolic syndrome that leads to CVD incident. With that, I'd like to thank everyone for your kind attention.
Thank you very much, Dr. C, for that very insightful lecture. Again, to remind everyone, if you have questions for our lecturers, you may type them on the chat box below. Please include the name of your speaker whom you want to address the questions to. I will be reading and directing them to our lecturers during the Q&A portion. If you are still unmuted, please mute your devices so we can hear our speakers more clearly. Thank you. Our second lecturer will be discussing the stroke best practices during COVID-19. She is the head of the Asian Hospital Stroke Center. She graduated class salutatorian from the Pamantasan ng Lungsod ng Maynila College of Medicine. She was the chief resident during her senior year at the University of the Philippines, PGH, where she took her residency in adult neurology. She had her clinical and research fellowships in stroke and vascular neurology at the National Neuroscience Institute of Singapore. She also leads the stroke services at Manila Medical and Perpetual Health Medical Center, Las Piñas City. Please welcome our next speaker, Dr. Jennifer Justice Manzano. Dr. Jen? Dr. Jen, we can't hear you. I think you're muted. Yeah.
Oh, can you hear me now?
Yes, Dr.
Okay. Thank you very much for that introduction. And I am honored to speak this morning alongside Dr. C and Professor Buena. This morning, I was tasked to talk about stroke care best practices during COVID. And when I was thinking about the content of this lecture, I thought best to, my screen is not sharing. I thought best about how we actually manage stroke in the time of COVID. So why do we have to talk about stroke management in the time of COVID? We have read so many things about COVID patients getting strokes and about strokes being the first presentation of COVID among some patients. So 25% of COVID-19 patients are actually have acute ischemic strokes. Most strokes among our patients tend to be in the elderly and among those with severe COVID-19 symptoms. Mortality is also increased among COVID-19 patients with a history of cerebrovascular disease. Lastly, stroke is a negative prognostic factor in COVID-19 patients. So I think it's really good to talk about first time stroke mute. May I ask everyone to please mute your microphones, and may I please ask the host to mute everybody except me. I have a naturally soft voice, which others might not be able to hear amidst all the noise. Thank you very much. So these are my disclosures. And this is what I will talk about. So we will talk about the goals of acute stroke care, the challenges in stroke care during the pandemic, and the lessons that we learned from these challenges. So the goals of acute stroke care are actually three-pronged. Number one, we have to limit disability, and we do that by actually decreasing the volume affected by the stroke. This is by reperfusing or reinstituting blood flow in the blocked artery so that we can resuscitate the area of viable tissue. And by doing so, this will translate into less disability for the patient. The second goal of acute stroke care is to prevent complications such as aspiration pneumonia and bed sores. And thirdly, to prevent recurrence of the stroke and other vascular events. Allow me to share with you so that we don't, I understand that the participants for this morning's webinar are not all neurologists, and allow me to show you this video that we did at Asian Hospital about stroke recognition. Is it playing?
No, Doctora.
Will it be possible to play this? None. So at any rate, this video actually talks about BFAST, which is the acronym that we use to teach people about how to recognize stroke. BFAST is an acronym for balance, so eyes, face, arm, speech, and time. So these are actually the most common stroke symptoms, and we teach everybody that have any one of these symptoms to come to the emergency room right away, because it is possible to reverse these disabilities if you come to a stroke-ready emergency room right away. So there are many aspects of stroke care. This was taken from the American Heart and the American Stroke Association. We have to recognize the symptoms, and in some countries where EMS is available, to activate EMS. We have to ensure timely EMS response and transport to stroke. In our setting, in the local setting, where EMS is actually very expensive or not available, we ask patients to come to the emergency room right away should they have any one of the symptoms of stroke. And once they come to the emergency room, the institution of guideline-based stroke care, and of course, quality post-stroke care. However, the current pandemic poses many challenges to these aspects of stroke care. For example, stroke recognition, it is already very difficult for patients to come to the emergency room should they have any one of the symptoms of stroke. And it is also difficult for them to recognize stroke. Worldwide, only 5% of patients actually come to the emergency room and get appropriate treatment once they get symptoms of stroke. Now, the pandemic has already instituted fear among everyone, and prevents everybody to go to the emergency room. Karaniwan natatakot sila, or they don't want to go to the ER for fear of catching COVID. In our setting, the cost of EMS is very prohibitive. It's very expensive, and especially in the current pandemic, when the patient himself will have to shoulder the PPEs of the entire EMS team. The availability of transportation from the patient's home to the emergency room poses a problem, especially during the time of quarantine, where public transportation. Some emergency rooms have also been closed to non-COVID cases. And of course, there have been pathway delays in terms of stroke care. There are interactions between stroke and COVID meds. And also, we have to institute some changes in the way we do procedures for stroke, such as mechanical thrombectomy. Lastly, there are challenges in terms of discharge planning, rehabilitation, and how the patient will follow up after the patient has been discharged from the hospital. So they say that the best teachers are our patients. And so allow me to share with you some of the cases that we have encountered during this pandemic. And we hope that you will learn from these patients the same way that our teams have learned from them. So to start off, I would like to share with you Mr. JC, a 48-year-old businessman who has controlled hypertension. He had recurrent symptoms. So if you were to look, his symptoms were initially very mild, just facial droop lasting 20 minutes. However, these symptoms kept on recurring, such that he had to overcome his fear of going to the emergency room, and went to the emergency room of our institution. We got him at 2 hours after he had left-sided weakness, along with his facial droop. And so we were able to give Altiplace. We were able to do IV thrombolysis on this patient. And luckily for this patient, his NIHSS, or his deficits at discharge, was just 1. For the non-neurologists, the NIHSS is a clinical scale that we use to quantify the patient's neurologic deficits. The lower the number, the less the deficits. And the MRS, which is the functional capacity of the patient, at 2 weeks is 0. So in the MRS, the lower the number, the more independent the patient. And 0 means that the patient went back to his pre-stroke level of function. But his case is different from Mr. AZ, a 63-year-old male who is a retired high school teacher. He is hypertensive with good control. He is also diabetic, but he is currently undergoing chemotherapy for colon CA. He has had a history of transient ischemic attack 2 months prior to his stroke, and he woke up with a right-sided weakness as well as dysarthria. However, because they did not have any transportation of their own, they were unable to find somebody to bring them to the hospital. So they actually asked for help from the local government. However, the ambulance that the local government was using was being used to transport COVID patients. So they were able to find transportation to the hospital only on the 2nd day after his stroke. And by that time that we got him, he already had aphasia and he already had hemiplegia, which means that he could not move his right extremities at all. And this is really a deterioration because from the outset, he only had right-sided weakness and a little bit of slurring of speech. And so this patient deteriorated because they were unable to go to the emergency room right away. And this is also another case, that of Miss AC, a 34-year-old female who also had mild symptoms of right-sided weakness and slurred speech. He arrived at the emergency room at the 5th hour, so she was already outside the golden period where we can give IV thrombolysis. In my 3 institutions, we use 4.5 hours from the onset of symptoms as the cutoff for IV thrombolysis. However, she had fever and cough. And so at the first emergency room that they went to, she was advised transferred to another hospital that can accommodate COVID suspects. And in the hospital that they transferred to, she was again advised to transfer to another hospital because they said they were full. And the long and short of it was that she was admitted at the 3rd hospital that she went to. And by the time that I saw him at Telemed after discharge, and this was about 3 weeks after the onset of her stroke, she was already completely plegic on the right and also with a very severe dysarthria. You could barely understand what she was saying. So these three cases actually portray the difficulty that the pandemic has imposed on patients with stroke trying to seek treatment. And like we said, there are many aspects of stroke care. And the 3 patients portray, number 1, the fear of going to the emergency room. Our first patient had kept on postponing until he suffered weakness of his extremities other than facial droop. And the unavailability of transportation to the emergency room, as well as the closure of some emergency rooms brought about by the COVID pandemic. So let us now, the lessons I've learned from these 3 cases are as follows. Number 1, pandemic or not, stroke still is an emergency. And the burden of disability will always be there. So we should not neglect stroke. And stroke will not stay at home. So we have to keep reminding to our patients that if they have symptoms of stroke, they have to come to the emergency room of an acute stroke-ready hospital right away. Also, there is a need to make known to the public which hospitals are stroke and COVID ready so that patients won't have to shop for emergency rooms, as in the case of our 3rd patient. In other countries, they really made use of technology. The following are some of the apps that they use in order to help the public know which hospital they have to go to, and in order to help the public recognize stroke, as well as to also help loop the entire stroke team in managing these patients, because there is challenge in terms of physically coming together to do appropriate case discussions about how best to manage these patients. So Smart Stroke 4.0 is actually an app that is used by the EMS in other countries. They use this to help in stroke recognition among paramedics. Likewise with CV-Aid. CV-Aid also helps the stroke team in certain decision making that in terms of management. Other countries have also used Join and Zoom in looping the stroke team together so that everybody who is on board the medical care of these stroke patients have a platform to talk about the case in a safe and confidential manner. PharmAlarm is actually an app that is used in Spain in order to help more patients become aware of their risk factors of stroke. And countries have used Google and Apple apps in terms of COVID tracking. And so that people will know which hospitals are already full in terms of admitting stroke patients who are COVID suspects. So we have to leverage on some of these technology in order to help us, help our patients navigate where to go should they have stroke symptoms during this pandemic. So earlier we said that there are many aspects of stroke care, and we've talked about the first three. Now let us go to the into the pathway itself. So there are these are actually also AHA and ASABs of stroke care. This is what the patient has to go through once stroke is recognized, and allow us to focus now on when the patient is already at the emergency room, and as the patient goes through the stroke pathway in the emergency room. So again, we go back to Mr. JC, our businessman who we talked about earlier. Again, he came at the ER with very mild symptoms, only an NIHSS of 5, and he came within thrombolysis window. But we were able to thrombolyze him at 4 hours. So what happened? He was at the ER by the 2nd hour of his stroke. However, he was thrombolyzed only at the 4th hour. And that was because the CT was being disinfected when he came in. And in that particular institution, we only have one CT scan. And so we were unable to do a cranial CT for this patient soon as he came in. However, we are blessed because the ER staff in that hospital are stroke proficient. And so because we only had a very limited time window, imagine we did a makeshift telemedicine for the attending neurologist. And so we were able to quickly TPA him with the remaining hours that he had. Luckily for this patient, he had only facial droop when he got discharged a few days after. And at 2 weeks, he was already back at his level of functioning. So very lucky for JC. However, this really upsets us because time is brain, we always say. And the concept of time is brain means that for every second that we are unable to reperfuse, we lose so much more neurons. And so the loss of these neurons translate to disability or brain aging. And so for Mr. JC, who had to wait 2 hours more, that actually could have translated to a greater disability for him. But he was blessed because when he got discharged, he only had facial droop. But not all patients are so lucky. We have KR, a 58-year-old female who arrived at our emergency room at 4 hours. She presented with dizziness, ataxia, dysmetria, dysarthria, so all posterior stroke symptoms. Her NIHSS score, and she would have been a very good candidate for thrombolysis. However, when she came to our ER, both the CT and our MRI were non-functional. And so we had to bring her to a nearby, to another stroke-ready hospital for thrombolysis. Unfortunately, she did not make the 4.5 hours cut off because she came to our ER at 4 hours, and we were able to arrive at the other hospital at 4.5 hours. But by the time that they were about to give the medicine, she was way beyond thrombolysis window. We also have Mr. RF, a 72-year-old man who was admitted for peripheral arterial occlusive disease, and on and the next day of admission, he was referred to neurology for a right hemi-neglect in the fascia. So we wanted to, because this was an inpatient stroke, it was we could have really helped the patient However, we had to do his CT scan in another hospital already at day 2 of the stroke, because again, the CT and the MRI in that institution happened to be non-functional at the time that we needed it. So on the second day, there is actually a clear infarct the left side of the brain of this patient. And so unfortunately for this patient, we discharged him with hemi-neglect as well as aphasia. So there are many other patients, but what about the elderly? Because the elderly population are actually more at high risk of getting severe COVID, as well as the worst outcomes in terms of stroke. So allow me to share the case of Mr. AB, as an 86-year-old man who was fully independent. So he was a good old person with a controlled hypertension, very compliant to his medications. He came to the emergency room 1 hour after right-sided weakness. So I don't have his angiogram right now, but his angiogram actually showed an occlusion of the left MCA, and he was a very good candidate for thrombectomy. However, we did not go through with thrombectomy anymore because number one, this patient was very old. He was 86 and he had mild symptoms. So we thought that the benefits of thrombectomy far outweighed the risks of thrombectomy in the current setup, no, in the pandemic setup. This is in contrast to Mr. XY, an 80-year-old male, also with controlled hypertension and who was dyslipidemic. He woke up with right-sided weakness, with right neglect, with the preferential gaze to the left and the aphasia. So we thought it was really a big left-sided hemispheric stroke. He arrived at the emergency room at 5 a.m. However, on examination, his O2 sats were only 88% and he had bilateral infiltrates on his chest x-ray. Now, this is his MRI showing really a big stroke, and his MRA showed left MCA occlusion. Now, if for Mr. XY, we really contemplated on doing mechanical thrombectomy for him because he was not really so old. He is 80-year-old. However, the severity of his symptoms as well as the volume of his infarct actually made us do a double take, as well as his other comorbids, such as in this case, moderately severe pneumonia from COVID. So he turned out COVID positive. So we decided not to TPA this patient because number one, he was already way beyond window. He was last seen well at 9 p.m. and he arrived at the ER at 5 a.m. And we did not do mechanical thrombectomy on this patient anymore. So in the time of COVID, we still follow guidelines for mechanical thrombectomy. However, it is really good to become conservative in clinical equipoise. And these are cases when there might not be more benefit compared to harm in doing thrombectomy. And these are for cases with both anterior and posterior circulation, large vessel occlusions with low NIHSS. If the patient has distal occlusion, if the patient has a low aspects score. For the non-neurologists, aspects is actually a scoring system that we use in the patient CT scan. The higher the aspects score, the lower the volume of the infarct. So if the higher the volume of infarct, we might have to conservatize. And also, if there is minimal or moderate penumbral tissue, usually we need a perfusion scan to determine this. There are other special considerations when deciding whether to thrombectomize the stroke patient or not. Number one, the age. Bearing in mind that there are higher rates of futile reperfusion in patients 80 years old and above. That means that even if we are able to get the clot from the occluded artery, and even if blood flows through the previously occluded artery, there might not be functional improvement in the patient. And so if there is clear, if there are clear issues, or if there are clear challenges in terms of deciding whether to thrombectomize the patient or not, we can actually make use of several pre-mechanical thrombectomy scoring systems. And these scoring systems usually take into account the patient's age, the patient's NIHSS, which is again a marker of how severe the patient's stroke is, the patient's blood glucose, how big the patient's stroke is, and the presence of vascular risk factors, and weigh these against COVID predictors such as lymphocyte count and CRP and LDH, which are all markers of endothelial dysfunction as well as inflammation. So again, there are many aspects of hyperacute and acute stroke care, and the current pandemic actually impacts on all of these of stroke care. Very briefly, allow me to walk you through how the current pandemic actually impacts the patient's journey soon as when he arrives at the emergency room and after an intervention is done. So when the patient arrives at the emergency room, other than screening for stroke, the patient needs to be screened for COVID symptoms. And this actually prolongs the time that we are able to intervene for the patient, especially if he is a reperfusion candidate. And of course, once the stroke alert is activated or the brain attack team is called, the stroke team needs some time to don the PPE. In some big centers, the stroke team is already at the emergency room, and that actually cuts the length of time that the patient needs to travel from start to finish of her ER journey. Also, previously, when the patient comes into the emergency room, the stroke team comes, and so the stroke team, during a back call, somebody will take the history, somebody will assess the patient in terms of NIHSS, somebody will insert a line, somebody will take labs. However, in the current pandemic, we have to limit, where we have to limit interaction with hospital personnel, then sometimes only one or two people actually come down to see the patient. And so this actually also adds more time to the patient's journey from the start to finish. Likewise, it might not be possible for the attending stroke specialist or neurologist to come see the patient right away. And so we have to leverage on telestroke. There are some institutions that are lucky enough to have this telestroke instituted already. However, in those who do not have telestroke, we can do makeshift telestroke. So we can make use of Viber or Messenger, but bearing in mind that these are sometimes not a very confidential way of handling the patient's data. And also, this is where empowerment of the stroke team in terms of competence really matters. So in my institutions, we are very happy that we have really invested in training everybody in terms of doing NIHSS, in terms of reading the scans, so that the attending neuro has a certain level of confidence when they refer the patient. And likewise, post-IV TPA or post-mechanical thrombectomy, we can revise some of the TPA monitoring that we have. Usually, or before the pandemic, we used to monitor patients who get thrombolized or thrombectomized every 15 minutes for the first 2 hours, every 30 minutes for the succeeding 4 hours, etc. So it was very labor intensive, but because in the current pandemic, we have to limit interaction of the patient with hospital personnel, we have to revise some of these monitoring. And lastly, if the patient is to undergo mechanical thrombectomy, we have to make a straight path or the shortest distance between the emergency room and the angio suite, ensuring that the patient will traverse or the patient will meet the least number of hospital personnel and the least number of patients on the way to the angio suite. This is also to limit their exposure to hospital personnel and to other patients. And also ensuring that in the angio suite, protocols are strictly followed, such as the use of level 4 PPE, limiting personnel in the angio suite, and also following intubation protocols. So there are other issues on stroke admission, such as mandatory swabbing of all stroke patients in the local setting where there are few labs that are able to handle PCR. This actually becomes a choking point because the results of swabs come in more than 2 days after, and so we do not know where to place the patients, and patients are actually damned in the ER. This actually limits the number of ER beds as well. The availability of beds in the COVID floors as well. And also in many centers, the acute stroke units have been reorganized to COVID units. And so the acute stroke patients are either brought to the regular floors, and there is a question about the competence of nursing staff in terms of taking care of these stroke patients. And likewise, we have to reiterate that the path from the emergency room to the patient's bed, wherever he will be admitted, should be the one with the least exposure to others. So with or without reperfusion therapy, acute care should follow the basic tenets and the guidelines for acute stroke still hold. So we still need to ensure adequate neuroprotection, and we have to ensure to follow guidelines. And again, we have to be guided by the 3 main objectives in acute stroke care. And it's very important to pay attention to drug interactions between stroke and the COVID medicines of patients who are taking this. So for our COVID patients who have stroke, or for our stroke patients who are COVID suspects, we have to pay attention to drug interactions. For example, Mr. XY, our gentleman who came in for left hemispheric stroke and who had bilateral infiltrates on chest X-ray, and who later on tested positive on NPS, had QT prolongation because he was put on hydroxychloroquine. This was in the earlier days of the COVID pandemic, where almost all patients received HCQ. And because the patient was put on xylostazole, on enoxaparin, and methylprednisolone, because his CRP, his LDH, his ferritin were so high, he also had upper GI bleed. And lastly, because he was placed on HCQ and he was also on insulin because of reactive hyperglycemia, he had hypoglycemic episodes. So the story of Mr. XY just highlights that we need to pay attention to drug interactions of COVID meds with the common stroke meds. These are actually some of the meds that have no known interaction with common COVID meds. Altiplase, the thrombolytic drug, aspirin, and neuroprotectants such as citicoline or Kalbe's Calbrain. But for patients who will be put on lopinavir and ritonavir, please bear in mind that these medicines will decrease serum levels of clopidogrel and ticagrelor. It will also increase serum levels of our novel anticoagulants. And tocilizumab may increase serum levels of insulin as well. And so we have to be careful and monitor these patients accordingly. We also have to bear in mind that COVID meds have neurologic effects that may impair stroke assessments. For example, HCQ may cause encephalopathy, and it may decrease seizure threshold. And so we might have stroke patients who become encephalopathic or have seizures. Corticosteroids may have psychotic symptoms or depression, even hyperglycemia and myopathy. Lopinavir and ritonavir may cause gastric upsets, so we have to cover appropriately with PPI. And tocilizumab may cause headaches and may induce hypertension as well as cognitive impairment and neuropathy. So we have to bear in mind these effects so that we can assess our stroke patients appropriately. Now we talked about these four, and now lastly, we have to talk about quality post-stroke care, and I'm talking about discharge planning, rehabilitation, and follow-up. For our 48-year-old businessman who was lucky enough to get thrombolized and get discharged with a very minimal deficit, and who went back to his previous level of functioning only at 2 weeks, the discharge was actually delayed because his son was quarantined in hospital. And so we did the discharge planning via telecon, and week 2 assessments were done via telemed. So we have to leverage again on technology in order to be able to plan for discharge and even do post-discharge consultations or follow-ups for these patients. Miss TC, an 89-year-old female who was admitted for a right frontal infarct and who had COVID pneumonia, luckily had good outcome despite the patient staying in hospital for about a month. But the main issues were actually dealing with family anxiety during the confinement and even after discharge. And the family verbalized that they received rare updates from the medical team. And so from this case, we thought of using telephones or video calls already for families of patients who get admitted to the COVID wards. And also, when this patient got discharged, the patient, the attending physician's contact details were not given. So the telephone numbers that were given were actually telephone numbers at the clinics. But during this time, the clinics were actually closed. And so they did not, no one was answering the landlines that were given. So the family was very upset because they did not know who to call on how to get in touch with their attending physicians after they got discharged from the hospital. So we learned very well from this lesson. And now what we do is actually to give either a business email address where patients can actually reach us post-discharge, or also we have learned that we can link our clinic landlines to mobile phones of our secretaries. We also learned to give daily updates using video calls. And we also learned how to use video calls so that the families can take a look at their patients or can virtually visit their patients who are quarantined at the COVID wards. So for Mr. AZ, a 63-year-old retired high school teacher, remember the first case, the one who had no transport to the emergency room and who arrived at the emergency room only at day 2 of the stroke. Inpatient rehab was not done because at that time the service was not available. And so we only did home rehab after certifying that the patient was COVID negative. But for this patient, it would have been really great if there was already tele-rehab, or if we thought of tele-rehab during that time. It would have been really good if we were able to start tele-rehab even while the patient was admitted at the hospital. So for follow-up, we can use telemedicine, but we have to bear in mind that there are legal issues to telemedicine. We have to make sure to protect our patients' confidentiality. Also, because patients, especially the elderly ones, might not be comfortable with technology, they and their carers just need time to adjust to telemed. In my experience, once they experience the convenience of doing telemed, they will actually request for you to just keep doing their follow-up consults via telemed if it can be helped. However, there are also financial issues because some of our patients might not have internet where they live. So this will pose as a challenge for them in using telemedicine for follow-up consult. Likewise, for face-to-face consults, we have to teach secretaries how to protect themselves, us, and our clinics, and we have to work with hospitals in screening patients and carers. So I've learned from these cases, from these patients of mine, that we can still retain quality of care despite restrictions brought about by the pandemic. I have to advocate for myself and my patient, and we have to explore technology. We have to look at best practices by others, and we have to collaborate with other hospitals. Lastly, we cannot forget the social aspect of care. We have to update patients' families and provide the means for them to reach us after discharge. So last, thank you very much. Stroke still is an emergency, whether it is and please let us not stay at home for stroke even during this time of pandemic. Thank you very much.
Thank you very much, Dr. Manzano, for that very timely lecture during this pandemic. As a reminder, please type your questions to our lecturers. I would like to remind everybody to please mute your devices as we welcome our next speaker. Again, I would like to remind everybody. Can we please mute our... Okay. As a reminder, please type your questions to our lecturers at the chat box below. I will be reading and leading them to our lecturers during the Q&A portion. Continuously mute your devices as we welcome our next speaker. They always say that we save the best for last. For our final lecturer, I am happy to introduce to you Honorable Virgith Buena. Honorable Virgith Buena is currently the chairperson, Board of Nutrition and Dietetics of the Philippine Regulation Commission. She's the first hospital-based nutritionist dietitian consultant in private practice in the Philippines, having started her practice at the Cardinal Santos Medical Center in 1991, where she still holds clinic at present. She maintains a foreign and local license and is a member of Academy of Nutrition and Dietetics in the United States and 5 of its dietetic practice groups. A multi-awardee alumna from Sestro Escolar University, Cochrane Fellow of the United States Department of Agriculture in 2007, and a consultant retainer, nutritionist dietitian of Philippine Airlines since 1993. Makes herself available and visible as a tri-media spokesperson for the profession. Everyone, please welcome Honorable Virgith Buena.
Sabi ka, honorable. Honorable Virgith.
Okay, is that the word?
Okay, thank you. Thank you, Dr. Christopher Flores, for that introduction. I'm glad I'm tasked with this very important topic, metabolic syndrome, and to address metabolic syndrome with nutrition and dietary management. Is my slide okay? Can you see it?
Dora, not yet. Please slide. Ay, Ma'am Bridget, please slideshow po.
Slideshow. Slideshow. Anda. Okay. Is it seen now?
Yes, ma'am.
Okay. Okay, thank you so much. Sorry for that delay. Again, I'd like to thank everyone for participating in this webinar. As Dr. Flores said, it's very timely that we have these topics that we are tasked to talk about. Now, of course, Dr. Rosa Alency ably covered the prevalence and the risks, and Dr. Jennifer, she had so many patients that, you know, we know already, we will be afraid to really get sick. You know, it's so hard. But this time, just sit down and relax and listen for the things that I'm going to share to you, like um, like I'll be sharing with you. Of course, I would have to do a review of the metabolic syndrome, but just very fast. And I'll be tackling dietary management of the different diets that will be related to the topic at hand. Then, of course, the symptom-focused dietary management. I'll be talking about macronutrients, whole food, plant-based, um, and I'd like to share with you um, something very personal with me. My case, I'm going to share with you so you can learn a lot from it. It's better to do my own sharing rather than getting my other patient's case. Um, and then, of course, I'd like our health professionals to be comfortable in referring your patients to the nutritionist dietitian. So I'd like also to share with you our law and how a dietitian works. Because like I know a lot of our medical professionals and other allied health professionals are not really aware how a dietitian works. So I'll be sharing on that. So I would talk about the core components of the metabolic syndrome. I'll just run through metabolic syndrome. Of course, we talk about Dr. Ross Allency talked about insulin resistance, high blood pressure, obesity, and abnormal cholesterol levels. But as she said, there are other definitions and would also include uh, um, high triglyceride and what's on the other side? Hypertension and insulin resistance. I've had so many patients who had that. And you know, we nutritionist dietitian, when we treat, we look at our patients. The most important, like for example, if we get their laboratory test, the one that needs immediate attention is one that we tackle right away. And most likely that will be um, when it comes to weight loss. Like I have here on my slide, the body shape. Now, it was also shown earlier that we have two types. The most common, of course, we have the apple shape and the pear shape. Now, for a nutritionist dietitian, we know that it's easier for us to make somebody who has an apple-shaped figure lose weight. But this one is more dangerous because it's nearer the heart. The pear shape is not as dangerous, but it's hard to remove. So these are the two. These are the difference between. This is the difference between the apple shape and the pear shape. Now the second slide here is I have a patient who has acanthosis nigricans. Acanthosis nigricans is a discoloration of the skin. And this is very common, especially with patients who have hyperinsulinemia. Now, as you can see in the slide, the, this is a black discoloration, thick black discoloration. But you know, the good thing about this, we can remove it. Oh my goodness. We can remove it fast. The longest time that I would do my I would do my I would give instructions to my patient and have her assess and go back for retest. Uh, the most would be 3 months, and that would be the most severe case. But how do you go about it? What you just do is you remove the sugar in your diet. It's just like when you remove the sugar, it's not as if you have taken glutathione and you have a clear skin and it's not expensive. That's the only thing that you have to do. And you will see the difference right away. And another thing, which is also common, is the narcolepsy, which is usually for those who have neurological problems, sleep problems. Narcolepsy is a sleep disorder, just like sleep apnea. Narcolepsy is a type of sleep disorder wherein a patient would have a hard time. Uh, he would always be feeling sleepy. So when I had a patient who had that, I would usually get near my patient, and the instructions that I give quite near him, because like I'm sure in a short while he will fall asleep. But once the weight goes down, then that is also gone. I had a patient who had narcolepsy, a guy who I made him lose 130 pounds in 11 months without medicine. And he the reason why he came to me was because he was going abroad and his mother wouldn't permit him to go abroad because of his weight. And he was going to take culinary course. And his weight, if I'm not mistaken, was 287. And he was telling me that before he came to me, he had 7 car accidents because like he would usually fall asleep while driving. And that's hard. So when he lost weight, it was gone. Sleep apnea. Sleep apnea would be 10% weight loss. Then I don't think you have to go for a sleep apnea test. And that saves you a lot of money for the procedure. And like I had this patient who was referred to me before he went for a sleep apnea test. He came to me because I was in the same hospital where the doctor who referred him was in the same hospital as mine. And then I said, okay, if you want to work on this fast, just follow me strictly. Let's see if we can do it for 2 weeks. You may not have to go on a sleep apnea test. And of course, because like the way he eats, he was really eating everything. And the wife said, mom, he makes sounds when he sleeps. He makes all kinds of animal sounds. And, I cannot sleep. And they said, okay, is it fine that you be strict with yourself? And he said, yes. And true enough, in a little over 2 weeks, he didn't have to go, he didn't have to use the CPAP. And we did it. And he was the guy I mentioned that who lost 130 pounds. Approximately, he was losing 10 pounds a month. And that's not hard. It's easy. And then on the side, I have the visceral fat. The visceral fat is the fat that covers the internal organs like the pancreas, the liver, the stomach. And you can just imagine if it covers, you really have a hard time breathing, hard time moving. And of course, as you can see in the slide, we have this weakness right after the skin. So the patient the fat is not only just one, not just inside, the one that's covering the organs, but also underneath the skin. Okay. Now I will be talking about the pinggan Pinoy. This is what we have. And before I go on, I'd like to remind you, July is the nutrition month. And it's just timely that we're talking about this. As you can see in my slide, we have the pinggan Pinoy, the healthy food plate for Filipino adults. Now it's divided into four, like the grow foods would be for the protein food, the go foods were for the starch and carbo foods, like the other half is for fruits and vegetables. As you can see, the fruit and vegetables is half of the plate. And you know what I usually ask my clients to do is to eat the fruit and vegetables ahead of the meal. So when you do that, your stomach is already full. If I can just mention to you, just try to visualize it. I have three samples of stomach. The calories that I'll be will be discussing will be only 400 calories. 400 calories. One would be oil, the other one would be meat, the last one would be fruits and vegetables. The oil, it will occupy only, not even 1/5 of the stomach. Now, the protein will occupy probably 1/3. But the fruit and vegetable will occupy the whole stomach, and that makes you feel full. You stop eating because you are full. And you would say, no, it's really something. I didn't realize I can have so much food in my life and enjoying it at the same time. So, okay, I'll go down to another. Oops, I'm sorry. Can you control it from your end? Okay, that's better. Okay,
Yeah.
I'll just use my. So here I have the macronutrients. The reason why I have to show this, because I have to give you examples. Like carbohydrates. Carbohydrates, you can see we have the bread, the rice, the root crops, the fruits, the vegetables, and the beans. And carbohydrates, we dietitians usually give 45% to 60% of the total calories. And it will depend on the medical condition of the patient. So what we do is we compute everything. Protein, the next slide, protein is 15 to 25%. It could even be more. It could even go up to 30%, because patients who are really malnourished would be needing more. So when we compute the calories for the protein allowance for the patient, that would usually be 1.5 to 2 grams per kilogram body weight. Now, but for kidney patients, we go down as low as 10%. The reason why we do that is because we want to make the kidney rest. Okay, so the next slide on the far right is the fat. Others, they go for any kind of fat, but I would emphasize the good kind of fat. And the good kind of fat, we have, of course, avocado, the nuts, the oils that are monounsaturated, like olive oil. Olive oil, we already consider, our coconut oil not as saturated, but it's more on the monounsaturated. That's a controversial issue. It was used actually against us, that we had to say that the coconut oil is saturated, so we have to avoid. But coconut oil is not just used for cooking. It's not just used for drinking. Coconut oil is antiviral, antibacterial. Coconut oil is also good for the skin as a moisturizer. I'm sure you would want to try that. And I can tell you, I've been using it as my moisturizer for the past more than 3 years. Okay. And as I said earlier, the prescription that we give to our patient will be computed accordingly. We have to weigh our patient, we have to do the nutritional assessment, and then we get their history. So the first session that we have is usually 45 minutes to 1 hour because we get every data that we need. And then after that, we can come up with our nutrition diagnosis. Our nutrition diagnosis is different from the medical diagnosis in the sense that medical diagnosis does not change, but nutritional diagnosis could change. Like if we have done something in the intervention that we give to the patient, and for example with diabetes, and then the blood sugar has gone down, the patient has lost weight, then the diagnosis would be different. Now the nutrition intervention, of course, will we select the nutrition intervention, and it is directed towards the root cause or the etiology or the nutrition problem, and it is aimed at alleviating the signs and symptoms of this diagnosis. Then, of course, we have the nutrition monitoring and evaluation. That's the final step of the nutrition card process, while the dietitian uses to determine if the client has achieved or make progress towards the planned goals. Now, the fluid requirements. Now, we don't really usually, a lot of people don't really pay attention to fluid requirements, but this is very, very important. You have to stay hydrated to stay healthy. Now, drink more water. What we usually recommend would be 7 to 8 glasses of fluids a day. But mind you, we do not consider coffee or caffeinated beverages as fluid because like it will make you go to the bathroom. So we don't consider that. But here, I also included on the other side, I also included a chart for you to know if you are hydrated or dehydrated. But the best thing that you can do is to look at your urine and then look at the color. Like clear would mean that you are hydrated. Light yellow, almost fully hydrated. Yellow would be moderately dehydrated. Bright yellow would be dehydrated, and dark yellow, severely dehydrated. But please keep in mind that there are some nutrient supplements that could change the color of your urine. So you have to be very careful. But another test that you can do is just pinch the skin of your patient, pinch the skin. If it does not return right away, then the patient is dehydrated. See, that's so easy. You know, sometimes when we see our patients, we actually do think we're just shaking hands with them, but of course this time we cannot do that. It's not part. It's part of the social distancing. We do not. In fact, we have to cover ourselves. But you know, during the normal times, it would be nice to hold your patient and test the grip of the patient because you would know if the patient is healthy or not. Okay. Next slide would be a whole food plant-based diet. Now, this is really encouraged for the metabolic syndrome medical condition and for the stroke patients. We go for the whole food plant-based diet. Now, as you can see, the bottom of the pyramid is the fruit. You can have all types. Consume 2 to 4 servings. 1 serving is 1 piece or 1/2 cup every day. And then vegetables would be all types also. You can eat as much. In fact, I would usually require at least a cup for lunchtime and a cup for dinner. But you can have more if you want to. The best thing that you can do for it to assure you that you can have your fruit and vegetable and you will love eating it, you can go to Pinterest and go to salad jar healthy. salad jar healthy. So it gives you different instructions on what fruits and vegetables to eat and what other things you can have. And when you have that salad jar, you can put it in the ref for 6 to 7 days because the vegetable is on top. It will not wilt. So you can put it in the ref, and before you go to the office, you can bring the salad jar with you. And then what goes in at the bottom would be the dressing, and then which is usually 2 tablespoons. The most would be 4, which usually I don't really recommend 4. Just 2 would be enough. And then hard vegetables, then the soft vegetables, then protein, then starch, and the fruit and the vegetables on top. So when you're about to eat it, what you do, the salad jar, you just turn it upside down and the dressing would go down. And then you can probably transfer it to a big bowl and then just eat it. It's so nice. You know, it's so nice to eat salad in a jar because it's so colorful. And you wouldn't really be hungry. I can assure you that. And then the next uh, part of the pyramid would be the lean leafy vegetables such as spinach, kale. We have our local vegetables. We have kangkong. We have talbos ng kamote. We have a lot. We have okra. Okra is, I plant my own okra. I have my own garden. It takes from seed to the time that you harvest it, it takes only 2 months. And when you run out of vegetables, it's so nice to have your own, and it's organic. So at least eat at least 2 to 3 servings, 1 cup raw or 1/2 cup cooked per day. Now then on this other side would be the whole grains. The whole grains would be like we encourage brown rice or unpolished rice, the oats, um, quinoa, amaranth, uh, whole wheat, whole grain pasta, and sprouted grains. Now, the serving portion is 6 to 11, and one serving is usually 1/2 cup, 1/2 cup, or a slice of whole grain bread. Now, do you know that a slice of bread, a regular slice of bread, is equivalent to 1/3 cup of rice packed? And you would say, oh, I'm not eating rice anymore. I'm just eating bread. But how many slices of bread do you eat? Probably you will be eating 3, and that's equivalent to 1 cup of rice. See, you have to know. We nutritionists, dietitians, we give exchange lists to our patients for them to follow. And it's so nice, but and then oatmeal. I usually have oatmeal in the morning. I would have 1/4 cup raw. We measure the raw oatmeal. You do not measure the one that with the liquid already. So you measure 1/4 cup. I put my chia seeds, 2 tablespoons. I put my non-dairy milk. I put my raisins as my fruit, and then I have my walnut. And it's heavy, I tell you, and me, I love it. I can't really go on without it, of course. But I have to vary also my breakfast. That is what we teach our patients. You have to vary your meals. Like a healthy balanced diet is something that will include all the food groups the whole day. And then we go for variety. For fruits, we vary our fruits. We don't just take one fruit, what kind of fruit a day, or one kind of vegetables a day. We vary because they have different nutrient contents. And the what's this? The the pasta is 1/2 cup. So when you have the nutrition, the food exchange list, that will guide you as to how much of the exchanges you would have. It's given to you by the dietitian because it's computed for you. It's not something that, it's not what we call in our term kahon, nasa kahon, or what it, uh, but it's really something that you have to vary. We include everything. Now, the plant-based diet is not all, you might misconstrue that it's all plant-based. we also allow uh, meat, but it should be limited, meat or chicken. Now, but eventually, if you go through it, you wouldn't really see the need. I have been on a meat-free diet for 2 years because of my thyroid. I had to remove the meat. I really wanted to lose weight, and then though I was not really that big, but I know I have to be careful with myself. And but that time I was sent to Iowa as Cochrane Fellow, and you know how Iowa is they have lots of cows. Excuse me, cows, pigs, and for me not to have meat was really something. I would be creating problem for my host. So then I was able to take that. But what I can say is like uh, not having meat for 2 years, I could smell the feeds. That's how it is. And then like we have a place for the legumes. The legumes are composed of beans, peas, lentils, seeds. You consume 2 to 3 servings per day. So 1/2 cup cooked legume is, or the seed is 1 tablespoon. It's already considered 1 serving. Now, like mongo, we are mongo eaters. No, the mung beans. Like it's usually considered by a lot of people as a vegetable. We don't consider that as vegetable. It is protein. It's a plant-based protein. So 1/2 cup of the mongo would be equivalent to 1 matchbox size of meat. And then it has 1/2 cup, one half exchange of the rice exchange or starch exchange. So when you have mongo, don't feel bad that you are, because like it's always construed that when you have the seeds, the mongo, that you know you feel you are deprived, and others think that you are poor because you're just eating that. No, but it can be a complete meal. But there's also another thing. Excuse me. There's also another thing that another legume that I have it very often, the lentils. I have the easy cook because like usually it would only take me 10 minutes to cook it. And then I put corn and a zucchini or squash, and then mix it with chili con carne flavoring, and that's it. I don't even put salt anymore. It's really very good. And the folate, the vitamin B12 is very high. It's really good, especially for the pregnant women. Now the high fat whole foods. you know, with the kind of diet that was very popular before, we would take any kind of fat, because you say, oh, it's fat, so I can have anything. I can have all this what you consider not the good kind of fat. But what we have is avocado, which is really in season now, nuts, olives, although it's expensive and salty, um, whole food sweetened treats, dairy substitutes such as oat, almond, rice, and soy. But this has, of course, to be used sparingly. Now, this whole food plant-based diet is just an example of what you can have. But again, please remember to consult a nutritionist dietitian because she or he can make it tailored fit for you. It will be computed for you. So, okay. Now, the next is I'd like to teach you how to read the food label. Now, this is very important. Even my grandchildren, they know how to read the labels because like they know that if like, for example, sodium is high, they don't have to get it. And as you can see here, the sample that I have is sample label for macaroni and cheese. It says there, serving size is 1 cup and serving per container is 2. So that means that for the whole container, if you finish the whole container, everything will have to be multiplied by 2. So that would mean if you consume the whole container, that would be 500 calories. And look at the sodium. The sodium is 470 milligrams. 470 milligrams, and what we consider as low sodium is only 140 milligrams. So can you imagine that? 470, and then if you double, that's already how much? It's almost close to 1,000. You know, 1 teaspoon of salt is 2,000, almost 2,500 milligrams. And when a doctor prescribes, for example, you're a hypertensive, the doctor would say, okay, uh, lessen your salt intake, and then and you, the patient, when you are not given the right instructions, if you don't see the dietitian, what you usually do is you remove the salt. But that is bad, because you will also have hyponatremia, and then hyponatremia will give you will make you disoriented. So it's too much of everything or too little of everything is not good. So we have to stay in the middle. In the same manner as potassium. Potassium, especially for kidney patients, is very, very important. If you are taking medications and then your laboratory test says it's high, you cannot be taking too much potassium. That's why the exchange list that I have in the clinic, I have exchange list for kidney patients. Then I classify my fruits and vegetables to low potassium, medium potassium, and high potassium. And then usually your health provider will say, "Oh, don't eat this. Like your potassium is high. Don't eat banana because it's very high. Don't eat an orange because it's very high." But you know, you can still have it. You know what you have to do? You combine the high potassium fruit with a low potassium vegetable, and you are at the middle. Or vice versa, you combine the high potassium fruit with a low potassium vegetable. So that's it. So, and when you want to lessen the potassium, you just have to soak your vegetables. We call it dialyzing the vegetables. So you throw away the water and you soak it in water probably 2 to 3 times, and then the potassium would be lower. See? Now, if you want to know how many teaspoons of sugar is in this 1 cup of macaroni and cheese. It says here sugar is 5 grams. Sugar is 5 grams and fat is 12 grams. What you have to do is you divide the 12 grams and the 5 grams sugar by 5, because 1 teaspoon is 5 grams. So that would mean that the total fat for a cup of macaroni and cheese would be about 2.5 teaspoons fat, and the sugar is 1 teaspoon. So be very careful when you buy processed foods, when you buy bottled foods, you know, especially the drinks, especially the drinks. You know, you are trying to lessen your calories, but you would consume you know, one bottle, I would just like to mention this, one bottle of soft drink would be about 60 spoons of sugar. That would be equivalent, actually, the calories would be equivalent to 2 exchanges of fruits. You can have a banana about 4 inches, and another one um, you can have a medium-sized orange or a medium-sized apple. So would you exchange your fruit with the what they call this, with the soft drink? Of course not. If you are conscious, if you are aware of that, and after my talk, I am pretty sure you will be conscious. You'll have to look at this and make sure to have an exchange list. Okay, and then you have to get enough of these nutrients. The best thing for you to study this is to share it with your family. Go and get a package of a bag of whatever you have at home, packaged food, and then study it and share it with your family. Teach them how to look at the fat content, the protein content, the calories, and then the sodium content. The cholesterol is low; it's only 30 milligrams. And then the protein is not one exchange, because one exchange of protein is 7 grams. Now, the carbohydrate, the total carbohydrate is equivalent. I use an exchange list wherein I merge the Filipino and the US. So I use 15 grams. It's easier for me to use, especially for my diabetic patients and for myself and for my clients who are not Filipinos. It would be easier for me to teach them that. So the total carbohydrate here would be 2 exchanges. It would be equivalent to rice. 1/3 cup is 1 exchange to 2/3 cup of packed rice. So there you are. It's easy. And if you will just follow the behavior modification technique that I mentioned earlier, eating the fruit and vegetable ahead, you'll feel full. You will naturally stop. You don't have to continue eating because you are full. And make sure with the children, with the kids at home, you tell them to make sure that their spoon is not so full, so that their mouth will not also bulge. Okay, so that's one. And then put their flatware down and chew it very well. Okay. Specific dietary recommendations. uh, excuse me. Limit saturated fat, trans fat, and increase dietary fiber. Do you know that dietary fiber is very important? Usually we are required to have 20 to 30 grams per day. And dietary fiber is not just, oh, it's already time. Okay, I'll just go fast, okay? I will just explain later on, or probably you have to consult a nutritionist dietitian in your place, so that they will teach you how to do it. So reduce intake of sugar sweetened beverages, moderate alcohol intake, restrict salt intake. Now, the oral nutrition support, this is very important. Just give me time. The nutritionist dietitian will consider current oral intake versus individual calorie requirement and may use nutritional advice as agreed with the patient and the family and the taste preference of the patient to ensure that the patient would like it and would meet the requirements. Usually I would come up with half a dose of medical nutritional every day. And the nutrition support may include high calorie or high protein snacks and drinks for fortification, oral nutrition support supplements including pre-thickened beverages. And then, of course, if the patient cannot anymore take the oral nutrition support, then probably they would be given the tube feeding. We have different kinds. We have the NGT, we have the NGT, we have the parenteral, the TPN, and all this I have encountered when I got sick. I told you I was going to mention about it. I had acute pancreatitis. I almost died 7 years ago, and I lost a lot of weight. I lost close to 30 pounds. And I was in the hospital. The first time I was confined was a month and 3 days. And then for the first 11 days, I was on TPN. But the good thing, because like prior to my getting sick, it was providential that I attended a simulation for nutrition support seminar workshop in the US, in Houston. And what I studied, only one out of the several diets that I studied, only one was not done to me, and that was through the pig. So I had my TPN. And then you know that, of course, the nurses who are listening, when the patient is given antibiotics, the antibiotics the feeding is stopped. Usually, like in my case, it was stopped for 3 hours. So what I told my nurse is, okay, deduct the 3 hours from 24. So I have only 21. The TPN bag is 1,900 ml. So divide the 1,900 ml over 21, and that is what you are going to give me every hour for the TPN. So I will not waste my PPL. It's very expensive. One bag would be costing about 8,000. I don't know how much it's going to cost now. So okay, so I was in the hospital, as I said, for a month and 4 days, and I was in a wheelchair. I couldn't walk. A lot of the doctors at the hospital saw me, and they were surprised when I was able to get back to my usual self. And if you see me now, it's as if I have not gone through that. But anyway, specific dietary recommendations include limit your limit your. Oh, this is the other one. Nutrition support. Okay, nutrition management for metabolic syndrome should be focused on weight loss and symptom management. That's what we do. As I said earlier, I look at the symptoms of my patient and that is what I address right away. And then if there is an improvement, I let them go back to their doctor for readjustment or for reassessment. Probably some medications will have to be lessened. The impact of diet on improving insulin sensitivity. You know, we count calories. I do carbo counting because, as I said, I'm diabetic. I'm carbo counting. I inject insulin in the morning before breakfast. I take my test also before dinner. So that would give me, because like I relate the insulin number of units with the food, with the result that I get, and I tell you I am in good shape, and my blood sugar is under control. Then the risk of developing chronic diseases associated with metabolic syndrome. Okay, personalized, multi-pronged approach incorporating diet and lifestyle changes as well as targeted supplementation. Another continuation of this is follow a healthy eating pattern across the lifespan. Focus on variety, nutrients-dense foods, and the amount. Your dietitian can do that for you. Limit calories from added sugars and saturated fats and reduce sodium intake. Shift to healthier food and beverage choices. Okay, and lifestyle recommendation: 30 to 60 minutes of daily physical activity. If you are smoking, stop smoking. For overweight and obese patients with metabolic syndrome, a prescribed healthy diet designed to achieve a weight loss of 5% to 10% is good enough. And you know, we target for a weight loss of usually 2 pounds per week and 8 pounds a month. Too much, to lose too much weight is not also good because you look haggard and you look sick. Okay, plant-based Mediterranean diet with or without energy restriction. DAS diet is diet approach to stop hypertension. And then a vegetarian component also is vegetarian diet is also a component of the treatment strategy. Primary intervention. Okay, IDF recommends healthy lifestyle that includes moderate calorie restriction to come up with a 5 to 10% weight loss in the first year, moderate increase in physical activity, and change in dietary composition. I mentioned to you how your diet should be composed. The above results help prevent and delay type 2 diabetes mellitus among high-risk patients with glucose intolerance. And the secondary intervention for those whose lifestyle was not enough and considered a high risk, drug therapy may be required to treat metabolic syndrome. And then treat individual components of the syndrome to lower individual risk associated with each components. It will reduce the overall impact on CVD and diabetes risk. What does a nutritionist dietitian do? Okay. The nutritionist dietitian look at the antecedents which are the factors that predispose the patient to illness, like the core medical symptoms and the genetics. The triggers, what are the triggers? Are factors that provoke the signs and symptoms. The mediator, the factors that contribute to pathological changes and dysfunctional responses. So we look at the lifestyle factors. We look at sleep and relaxation. We look at the work and life balance. We look at exercise and movement. We look at stress and relationship. And you know what? A registered nutritionist, dietitian, practitioner are equipped in all these areas, and because our expertise is on nutrition. Okay. Nutrition works. Intervention with a registered nutritionist, dietitian really is for the best interest of the patient. Now, I'd like to mention this because a lot of our listeners are not aware that the Nutritionist Diet Law of 2016, R8 2016, we look forward to a level of certified competitiveness that will make us competitive not only with the Asian economic community, but also globally as well. Now here, I'd like to show you this. Oh gosh. Okay. This is my last slide. This is how we are doing with our profession. We already have our accredited integrated professional organization. We are going towards specialization. We are developing our practice groups all over the country for all dietitians. And we have our CPD operating guidelines. We accredit CPD providers, companies who would like to am I out?
One slide back, ma'am.
Okay, I'm sorry. Okay. We come up with CPD seminars. Our seminar like this one, the webinar would be accredited if they applied, but sometimes it takes time before, especially now that it's pandemic. But don't worry, you can charge it to self-directed learning. Now, I'd like to tell you this. This is something that I feel proud. We have a reciprocity agreement with the US, and we are the only Asian country who has this. Our nutritionist dietitians, if they have experience of 3 years, they can apply for a verification statement and they can take the RD or RDN examination of the US here in the Philippines already. So we have also our standards of practice. So, we have our global network. We will network with the Academy of Nutrition and Dietetics, and of course, the Asian Federation of Dietetic Association for ASEAN and international recognition. So that's my last slide. I'll be welcoming questions later. Thank you.
Thank you very much, Honorable Virgith Buena. I hope everybody learned at least one or two from our renowned speakers. Now we move to the questions that you've sent to our speakers to answer. With the interest of time, I would only entertain one question per speaker. So let's go for the first question. This is to Dr. C. Dr. C, are you available?
Yeah, I'm here.
Okay. Dr. C, during this pandemic where elderly patients have less mobility, can fiber significantly manage dyslipidemia, and can fiber contribute to the reduction of statin dosage or use? This question came from Naga City.
Yeah, thank you very much for that question. In the past, it has been said that eating fiber can lessen. Can you hear me now? Can you hear me now?
Yes, ma'am. We can hear you clearly.
Yeah.
Yes.
Regarding the question, in the past, it was thought that taking your oats in the morning, cereals in the morning because of its fiber can decrease dyslipidemia. But unfortunately, so sorry to say that it might probably help a little bit, but it won't be enough to really bring down your lipid levels to the goals that is the target of our plus as well as the PHA target. As you know, diabetics are high risk. In itself, it is a cardiovascular disease. So we need to really keep their triglyceride and lipid profile at the lowest level or acceptable level. So the LDL should be less than 70 or less, while the total cholesterol should be less than 200 and the triglyceride less than 150. So going back to the question whether fiber can help, it might help, but it is not the treatment for high cholesterol and triglyceride.
Thank you very much, Dr. C. Now we move to the question to Dr. Manzano. Dr. Manzano, are you ready? Are you still there? Dr. Jen? Okay. First go to the question for our Professor Buena. Actually, Professor Buena, you have a lot of questions, but I am only going to choose one. So, how can disease-specific formula for diabetes address the caloric needs of stroke patients, and how can we manage their eating difficulty like stroke cases with dysphagia? This came from also a nutritionist from San Jose del Monte.
Okay. When we as I mentioned earlier, we do the calorie count. We look at the calorie needs of the patient, and it's included in the computation. We have to include it in the computation. So this is what I tell my patients. If I prescribe something, um, I tell them, and I usually give them a copy of the computation that I have, everything, so that I also tell them to give it to their doctor, to show it to their doctor, so their doctor will also feel comfortable. And I tell them that if it's included in the computation, uh, they are not just free to remove it, because otherwise the calories would go down. Okay, so
Okay.
it's part and parcel of the total calorie requirement. And for dysphagia, what we can do is like we can have several ways of making it palatable. I know the usual complaint, it's too sweet. So what I do with my patients, I compute for the whole day how much I gotta give them, and then I spread it out, and then come up with a diluted form, and probably to let them add nuts gelatin and other things. They can really do a lot. It's up to the dietitian to tell them what to do.
Okay. Thank you very much, Professor. Now, Doc Jen, are you still there? Or are you? Yeah, okay. You okay, you were there, but you couldn't unmute your device. Okay. Rather simple question, Doctora. What's the appropriate dose for citicoline in stroke patients with COVID?
There's so there are still no clinical trials on citicoline for stroke patients with COVID, but in the clinical trials for stroke patients, 2 grams per day IV was used. So if we were to use this for stroke patients who have COVID, then I would recommend that we use the same dose, because this is what was used in the clinical trials. So
Okay.
again, no data regarding stroke patients with COVID, but the data for stroke patients is 2 grams per day.
Okay.
Thank you.
Thank you, Dr. Manzano. Okay. Sorry for with the interest of time, we couldn't answer all your questions. Thank you very much for your questions, and I hope our speakers were able to answer them for you. I am now passing the screen to Mr. Donny Bambang for our closing remarks. Again, I am Dr. Christopher Flores, your moderator for today. Goodbye and good morning, everyone.
Thank you for all the participants for joining our webinar today with the topic Collaborative Strategies for Metabolic Syndrome Management, brought to you by Kalbe International, supported by Citicoline Calbrain, Neuro Repair and Neuroprotection in Cognitive Impairment and Stroke, and Diabetazole Nutrition Powder for Diabetic. You are also invited to join our next webinar, which is Current Trend in ICU Nutrition, that will be held on Tuesday, July 28th at 3 until 4 p.m. We hope with all the information that already given lecture by all of our honorable speaker and moderator today can help all of the participants on your daily routines. Thank you very much from Kalbe International, Philippines. See you again. Thank you.
Thank you very much.
Thank you. Stay safe.
Thank you.
Thank you, Dr.
Thank you, everyone.
Thank you,
Thank you,
Dr.
Thank you,
everyone.
Thank you,
everyone.
Dr.
everyone.
Rosasi, thank you. Dr.
Thank you.
Flores,
Thank
thank
you.
you very much.
You're welcome. Thank you.
Thank you, everyone.
Thank you.
Bridget, thank you.
Thank you,